I'm Dr. Marcia Sorensen. I'm a developmental optometrist at the Visual Symptoms Treatment Center in Arlington Heights, Illinois. And we're going to talk today about recent research that supports a vision therapy-based approach to treating amblyopia. And since we've got a pretty small group, you guys have entered the meeting muted, but you can feel free at any time to unmute yourself and ask me questions as I go. So, amblyopia is a neurodevelopmental vision condition that the American Optometric Association defines as a reduction in visual acuity less than 20/20 in the absence of any eye disease. There also has to be an amblyogenic factor that occurs before age 6. And those amblyogenic factors can be having a high prescription in one eye, but not the other, which is known as ANISOMETROPIA, or having a constant unilateral eye turn. So the eye can either turn in or turn out, but that turn has to be constant in order to develop amblyopia, or being born with a congenital cataract. So a cataract causes blurry vision, and even after the cataract is removed, the patient often has amblyopia because the eye with the cataract didn't get the same developmental experience as the other eye. So one of these three things has to occur before age 6 in order for amblyopia to develop. So for a long time, it was thought that amblyopia could not be treated after age 6 because there's a critical period for neurological development that occurs during that time period. The recent research has shown that that's actually not true, and that amblyopia can be treated in older children and in adults because the brain actually does have significant neuroplasticity and is capable of change. The amblyopia affects about 2% of the population and is responsible for more vision loss than trauma and ocular disease in people who are under age 20. So that means it's a big cause of vision loss in younger patients. It's also still a leading cause of vision loss in adults. So people who are aged 20 to 70, we know that people that are 70 and older, there's a lot of eye disease in that group. But amblyopia still is pretty high in causes of vision loss in adults. We also know that for some reason, people with amblyopia are at a higher risk of having an injury to their better seeing eye. No one really knows exactly why that is, but that's been shown in multiple studies to be the case. And we also know that diseases often attack the eye with better functional vision first. No one's sure exactly why that is either, but one of the things that happened that actually spawned a lot of this new research and revisiting amblyopia mechanisms and treatment was because patients that would get macular degeneration in their dominant eye and the vision in the amblyopic eye would then improve. So that caused, doctors and researchers to be a little bit more interested in amblyopia and treating amblyopia. So amblyopia, the hallmark of the condition is having reduced visual acuity in one eye, but amblyopia causes more than one problem with vision. So visual acuity, I essentially think of as being how small you can see. So you're looking at high contrast letters on an eye chart and seeing how well you can tell what those letters are. Contrast sensitivity is another thing that is reduced in amblyopia. So contrast sensitivity is more how well can you tell, you read something that's light gray on a dark gray background. And that translates to the real world in a lot of ways. When you're driving, if you're driving in the rain, contrast sensitivity is important because things are not well differentiated. Or if there's a gray car on a gray road, you're using contrast sensitivity to notice that gray car. The amblyopic eye also has inaccuracies in focusing. So when we look at things up close, our eye has a lens inside of it, and the eye has to focus to make small print clear. And often our amblyopic eye doesn't have as much focusing ability as the other eye or as much or as accurate of focusing. And that means that when a patient with amblyopia looks at things up close, their dominant eye is kind of taking over because their amblyopic eye is lagging behind. And that can also give the patient some double vision or some increased strain when they're looking at things up close. We also have unsteady fixation and poor eye tracking skills in the amblyopic eye compared to the other eye. And what that means is how well you can look at something and keep your eyes steady, that's fixation. And then eye tracking, that's how well you can follow a moving object with your eye, or how well you make reading eye movements back and forth when you're looking at a book. We also have reduced binocularity. And what that binocularity means is that's how well your eyes work together as a team to give you a three-dimensional perception of the world. And we know when we have reduced vision in one eye, that eye is not contributing as much to the team. And we often have reduced 3D vision and some of those kinds of things. And that contributes to spatial uncertainty as well, because we use our three-dimensional vision to figure out where we are in space. So the first round of studies that took place in the early 2000s is the Pediatric Eye Disease Investigator Group Amblyopia Treatment Study. And they had a couple of goals. One goal was to take a look and see how much just having the correct prescription in place helped amblyopia. Another goal was to figure out what the minimum amount of patching to be effective was. The reason why that is of interest is because patching has been the mainstay amblyopia treatment for a long time, but compliance is often poor because kids don't really like wearing an eye patch over their good eye and then trying to see out of an eye that can't see that well. It's not really the most fun thing in the world. So sometimes getting kids to wear the patch can be rather difficult. They wanted to see what the minimum was, basically to make the biggest gains. They also wanted to take a look at the effect of patching in kids that were a little bit older. Like we talked a little bit about at the beginning, for a long time, people thought amblyopia couldn't be treated past age 6. So they wanted to really explore that effect in kids that were a little bit older. And they also wanted to take a look and see how stable the gains in visual acuity were in patients that did patching therapy after a year or more, how stable those things were. So they found that with glasses alone, if people had not previously been corrected, just having the correct glasses made a pretty big difference for people that have a high prescription in one eye and not the other. About 80% of people had some improvement just by wearing the correct glasses. In patients that had severe amblyopia, which is 2100 or worse, they found that 6 hours of patching basically had the same effect as patching all day long. So 6 hours in that group was the minimum amount to be effective. In moderate amblyopia, which is 2040 to 2080, they found that 2 hours of patching has about the same effect as 6 hours of patching. So less patching was needed to be effective in that group. And then when they took a look at patching in older kids, they found that patching was better than just wearing glasses in kids that were 7 to 13. And then when they looked at kids that were a little bit older, patching was not effective unless no prior treatment had been attempted. So if patching therapy had been tried in the older kids when they were younger, but they had reached a plateau or not made progress, doing patching again did not seem to provide any additional benefit for them. They also found that in about 20% of patients, visual acuity regressed at the 1-year follow-up. So that's actually a pretty high rate of regression. That's about 1 in 5 patients. And the reason for that regression is likely that when we do patching and don't do any additional therapy, patching can improve the vision in the amblyopic eye, but it doesn't help binocularity. It doesn't help how well the eyes work together. And having the eyes working together when we walk around with both eyes open is important for keeping those gains in visual acuity stable. So the first group of research we're going to talk a little bit about is perceptual learning. And perceptual learning, there was quite a few studies done on this in adults to see if this method of training would improve their acuity. And basically what perceptual learning is it's repeatedly doing visual discrimination tasks. So they have patients do, a number of different things. So some studies use, how well can you line up these lines? How well can you look at these grading patterns and figure out which one is darker than the other? Or can you tell when the grading is just noticeable? Or how well can you pick out this picture from a crowded background? How well can you look at these dots and figure out which ones are moving? Various different things like this. And they found that perceptual learning does improve visual acuity in adults, but it didn't appear to have any effect on binocular vision. So because perceptual learning was found to improve acuity, they also took a look at video games with adults playing with the amblyopic eye. And they tried to use video games because a lot of judgments you make in video games are kind of similar to some of the things they do in perceptual learning. And one of the studies actually takes a look at first-person shooter games, because in those types of games, you have a little cross target, and then you're trying to align it on moving things. And that cross target alignment is very similar to some of these perceptual learning activities. So they found that monocular video game play in adults was effective at improving both visual acuity and contrast sensitivity. And then they decided to take a look and see, well, if we know that perceptual learning can make improvements, how does that compare to patching therapy? And they found that about 10 to 20 hours of perceptual learning produced the same gains in acuity as 100 to 160 hours of patching in children. So that's a big difference. So really what that helps tell us is that what you are doing while you're wearing an eye patch is very important. It makes a big difference. So while we're wearing an eye patch, we need to be doing things that stimulate vision processing. We want to be doing tasks where we are looking at things and figuring out what's the same, what's different, or can you pick out what's important in this sea of noise, and some of those kinds of things. So working on vision processing tasks while one eye is covered makes bigger gains in visual acuity than just wearing the patch alone. So those studies did help show us that there's what's called neuroplasticity in the adult brain. And what neuroplasticity means is it means that the brain is capable of making changes. So our brain is made up of white matter and gray matter. And that matter is then made up of neurons, which have synapses, axons, and dendrites that they use to communicate with one another. And with those communications, they kind of form pathways. And those pathways can be activated, they can be upregulated, they can be downregulated. So when we do these tasks that involve visual attention, visual perception, or visual motor integration and target these vision processing pathways, it causes changes in pathways in the visual cortex, which is the part of our brain that processes vision information. So this causes changes in cell activity, so which cells are turned on, which ones are turned off, and how active those cells are. And then that activity within the cells then changes how those neurons communicate with one another and which pathways are activated and some of those kinds of things. So this activity basically affects structural plasticity. So when these cells get activated, they're going to form new neurons or new dendrites, and then those pathways in the brain are going to become strengthened, and then ultimately that causes changes to the gray and white matter in the brain because we have more tissue being activated. So next we'll talk a little bit about suppression. This is another area of vision science research that's been taking a look at amblyopia recently. And suppression actually has been thought to be an important component of amblyopia for a long time by people that do vision therapy. And what suppression is it's an inhibitory intraocular interaction. So what that means, when we have both eyes open and the amblyopic eye's image is blurrier than the better seeing eye's image, the brain kind of chooses to ignore the amblyopic eyes image and relies more heavily on that dominant eyes image. So it's basically a brain adaptation to kind of shut off the blurred image from the amblyopic eye and rely more heavily on the clear image from the dominant eye. So what some of these research studies have shown is that people with amblyopia do actually have pathways in the brain or cells in their brain with connections that respond to both eyes, but because of this suppression process, when it's present, people are processing information just with one eye, so it's kind of rendering the visual cortex functionally monocular. So when we process visual information, we first process information in our primary visual cortex, and then that information travels through the dorsal stream to tell us where we are and where things are in space, and the ventral stream to tell us what things are. And so suppression first occurs in the visual cortex, but its presence affects how things are processed in these other processing streams. So if they're used with one eye or with both eyes. And we now know that suppression is mediated by a neurotransmitter called GABA, which has an inhibitory effect. And that if we reduce GABA inhibition, it helps restore plasticity in the visual cortex in these higher level areas. So in a laboratory setting, research groups attempted to quantify suppression or figure out how much suppression was present. So what they did is they basically adjusted contrast of the dominant eye. So they reduced it until they measured a point where the brain was perceiving images from both eyes. So in this picture here, one eye would see kind of a series of dots moving randomly, some noise, and then the amblyopic eye would see a series of dots that are all moving in the same direction. And they measure where the brain would perceive both of these at the same time. And they called that kind of like the balance contrast point. So basically they quantified suppression by saying that the amount that contrast needed to be reduced to the dominant eye was how much suppression was present. So we also have ways to evaluate suppression in the office, in the clinic as well. So my favorite way to do that is called the Wirth 4-dot test. And with that test, you have the patient wear red and green glasses, and the right eye sees 2 red dots, the left eye sees 3 green dots. And if the patient sees 4 dots at the same time, that means that their eyes are working together. If one eye is suppressed or shuts off, then its dots go away. So if my left eye is suppressing, I'm just going to see those 2 red dots that come from my right eye. If my right eye is suppressing, I'm just going to see those 3 green dots that come from my left eye. And then we can hold this test at different distances to evaluate the kind of depth of suppression or the severity of suppression. When I hold the target close to someone, it takes up more of their visual angle than when I hold it further away. So I know that someone has stronger suppression if they suppress one eye both up close and at far than if they just suppress at far. And this method has been shown to correlate well to the random dot method that the researchers used in the laboratory setting. So another important aspect of amblyopia is what's called stereopsis. The stereopsis is a measurement of 3D vision, and stereo tends to be reduced or absent in patients who have amblyopia. And the reason why 3D vision is important is because it helps us figure out where we are in space. And it's also important for maintaining the gains in visual acuity that are made by treating amblyopia. So whenever I'm working with patients in a vision therapy program, and I'm reevaluating them every 8 to 10 sessions or so to see how they're doing, I'm not only looking at visual acuity, but I'm looking at suppression and stereopsis as well. I don't always get improvements in all three of those things at every follow-up, but I know that if one of them improves, that the condition is improving. So then researchers took a look at suppression in anisometropic amblyopia. So that's the type of amblyopia caused by having a high prescription in one eye and not the other. And they found that the depth of suppression correlates to the reduction in visual acuity. So that suggests that suppression is a pretty big player in that acuity reduction. They also found that the depth of suppression correlates to higher prescriptions. So if somebody has, no prescription in one eye and they're +5 in the other eye, that person had more suppression than someone that was had no prescription in one eye and was +3 in the other eye. They also found that reduced stereopsis was associated with higher suppression, and that makes sense because we know if both eyes aren't contributing to the team, it makes sense that your stereo vision is going to be reduced. And one of the biggest takeaways from this is that the results were the same in both children and adults. They didn't show different trends. So since for a long time people were not treating amblyopia in adults, for this research to suggest that the characteristics are actually very similar, they're not different, is kind of a big deal. The researchers also compared suppression in strabismic and anisometropic amblyopes, so patients that had amblyopia caused by an eye turn and patients that had amblyopia caused by a high prescription. And they effectively found no difference in the suppression patterns between different types of amblyopia. And in all cases, deeper suppression was associated with worse visual acuity and reduced stereo acuity. They also found no age trends when they compared this group. So again, that's a big deal for our adult patients who previously, historically really aren't being treated. And they also found that the method of quantifying suppression correlates well to the Worth-Fordat test. Some other research groups took a look at the depth of suppression and the effectiveness of patching therapy. And 3 out of the 4 groups found that children with lower levels of suppression respond better to patching therapy. And the reason why that is important is because patients with higher levels of suppression were not responding as well to patching therapy. So that may be a reason why some patients get really good success with patching therapy, but some do not. Some people, when they do patching therapy, they kind of reach a plateau with patching alone. So maybe they started out seeing 20/80 out of their amblyopic eye, but then after 6 months of patching, they see 20/40, and then the vision kind of stabilizes. So those types of patients may respond better to a binocular treatment approach that's designed to reduce that suppression, since we know that patients with higher suppression aren't responding as well to this patching therapy. So researchers also kind of used their measurement technique as a training technique for improving amblyopia. So essentially what they did is they kind of remeasured that binocular combination threshold where they had reduced that contrast to the dominant eye, and then the brain used information with both eyes. They basically just remeasured that again and again, kind of working close to that threshold. And then they found that after about 2 to 6 weeks of treatment, that visual acuity improved in all these patients. And this is a small research study. They only used about, let me go back to my previous slide there. There's only about 9 patients involved in the study, but they were all adults and all had strabismic amblyopia or had eye turns. And acuity increased in all these patients. And a lot of patients gained stereo vision who did not have it before. So this is a big deal for patients, adult patients that haven't historically been offered amblyopia treatments. This gives good evidence that improvements can still be made well into adulthood by using more of a binocular treatment technique. So taking that into account, researchers then decided to make this into more of a engaging game that someone could do at home. So they tried to design an anti-suppression variable contrast TETRIS game by which one eye saw some of the blocks and then the amblyopic eye saw some of the blocks. And then you could manipulate the contrast so that the amblyopic eye could, so that both the blocks were able to be seen at the same time. And what they did was they divided their group in half and had half the group of adults play Tetris monocularly with their dominant eye patched. And then the other half of the group play this game with the binocular anti-suppression design. And they played for an hour a day over 2 weeks. And the group that did the binocular training improved more than the group that did the monocular training. So they improved in acuity, stereopsis, and suppression more than the monocular group. And again, this is a small study, so there was about 5 patients that attended the follow-up, but their gains did remain stable at that follow-up, which is promising. Taking this research into account, there were actually some larger scale research studies done in 2017 and 2018 using this technique. So what they did is they designed kind of like a home iPad game for kids to play using this variable contrast anti-suppression design. But the gains in this study weren't as effective. What the researchers kind of found was the compliance of this technique was not as good. So rather than getting the prescribed 1 hour a day of treatment, kids were only playing the game for maybe 15 minutes or 30 minutes. So the gains were not as high as they expected. There's probably some additional research that needs to be done to figure out exactly kind of what the optimal dosing of this type of treatment is. This gives good evidence that using a binocular treatment approach is beneficial for reducing suppression, improving visual acuity, and improving how the eyes work together, and that it could be a good treatment method for adults. So we have a number of different ways we can work on anti-suppression in clinic, but the most common way is to use red and green glasses. And then we can create different scenarios that give the patient feedback about if both of their eyes are working. So you can see in my example here, I have some red and green filters put over a computer screen. And then if one eye shuts off, half of the computer screen goes dark. So it gives people feedback about if both of their eyes are working, because if they are, then they can see through both of the filters. But if one eye shuts off, they can only see half of the screen. And then we also have anti-suppression cards, which can be a lot of fun. Those are more engaging, especially for kids. But it's set up the same way where one eye sees some of the cards, the other eye sees some of the cards. So both eyes have to be working to be able to see everything. And then another way we like to set things up while we're doing anti-suppression activities with patients that have amblyopia is to do something called monocular and a binocular field. And what that means is we create kind of a scenario where the amblyopic eye has to be working to be able to see the object of interest or see what's going on. So for example, we can have somebody use a pink highlighter, red pencil, red crayon, and use that to color or draw while they're wearing red-green glasses. And then what happens is that red color cancels with our red filter. And so the amblyopic eye wears the green filter, and it has to be working to be able to see what's going on. So if the amblyopic eye shuts off, then the patient can't see anything. They can't see what they're drawing, what they're coloring. It goes away. And then these are just some other examples of anti-suppression activities. So we can match tiles, we could do mazes. There's a lot of different ways and different ideas you can use to do anti-suppression therapy. Another tool that we recently got in our office is the Optics Trainer Virtual Reality Program. And that's a program, it's a virtual reality headset, and there's a number of different games that you can do with it. But the cool thing is it has the option of being able to reduce contrast to one eye. So I can sort of create a situation that's similar to the laboratory studies where I can reduce contrast to the dominant eye to give my amblyopic eye an advantage. And then I can have the patient play a number of games that involve the depth discrimination. So they have to figure out, which of these birds is closest to them, or figure out how to hit something, or some of those kinds of things. So that's been a really great tool that I've enjoyed using, and that is based on this research. It's a really nice tool to have. Another thing that we often will do for patients is we'll use what are called Vanguard or occlusion filters. And what those are is they're a kind of like a sticker filter that we could place on somebody's glasses that creates some blur or some contrast reduction. So rather than having that eye patch, if we reduce contrast to that eye and blur it a little bit, then it kind of forces the amblyopic eye to take over and work a little bit harder, since we've kind of reduced the dominant eye signal a little bit. The goal when we set up that technique is to kind of create what's called a barely blur situation, where we blur the dominant eye just a little bit beyond the amblyopic eye, so that the amblyopic eye kind of picks up and then does more work. So kind of the main takeaways from this recent research, kind of what I describe as, how I treat amblyopia is I want to do a combination of monocular work and binocular work. So I know while someone is wearing an eye patch that I want them to do tasks that emphasize visual processing. So I want them to look at pictures and figure out what's the same, what's different, or be able to look at a picture where a lot of things are going on and pick out the important details, or be able to reach out and touch things and kind of figure out where things are in space. And then I want to work on anti-suppression training with them. So I want to do a lot of those types of red-green activities, especially where I create situations where what they're looking at has to be seen by the amblyopic eye. And then I want to kind of have a phase 3 where I work on really enhancing that binocular vision that we've developed to help maintain the gains that we've made and make sure that things remain stable. That's kind of an overview of kind of what my ideal amblyopia treatment approach is based on all of this recent research. But kind of our main takeaways is that we know that binocular training is beneficial to reduce stereopsis and improve visual acuity, and that type of treatment is beneficial even in adults. So like we talked about at the beginning, adults haven't always been offered amblyopia treatment, past a certain age, because people thought for a long time improvements couldn't be made. But this shows that this type of treatment may be more effective for adults than patching. So it's a good thing to keep in mind, and a good thing to offer if you have patients that are adults and they have amblyopia. And we know that reducing suppression is an important part of therapy, and that may be particularly important in cases that do not respond to patching or reach a plateau with patching. So if you have somebody who, they were patching for a while, but they've kind of reached a plateau, they haven't made any improvement for a long time, but their acuity is still not good, treating that suppression may help them gain additional benefits. And we know that if we emphasize tasks that involve perception, visual attention, visual motor integration during patching, that helps create change or creates neuroplasticity in our visual cortex. And we know that improving binocular vision helps maintain the gains in visual acuity after we stop amblyopia treatment. So we want to try and minimize regression for patients as much as possible. So those are my references. And then I'm happy to take any questions that anybody has. If you want to either unmute yourself and ask them, or ask them in the chat feature, either one would be okay with me. And then I did also publish a paper on this topic a couple of years ago. So if anyone would like to take a look at that paper, if you want to shoot me an email, I'd be happy to send it to you. So seeing that there are no questions, I'll hang out for another couple of minutes here. But thanks so much for taking a little bit of time out of your evening to learn more about amblyopia. And feel free to shoot me an email if you'd like a copy of my paper or have more specific questions. All right, thanks for coming and have a great evening, everyone.